Hi, and welcome everybody to our CCDD seminar series. This week, I am super excited to introduce Dr. Molly Franke. Professor Franke is a global health researcher who brings the rigor of epidemiology to intractable infections, including tuberculosis, cholera, and HIV. A primary objective of her work is to reduce suffering from infectious diseases by applying rigorous epidemiological methods to address critical knowledge gaps related to interventions and treatment. Examples include the design of studies to assess the effectiveness of cholera interventions, including vaccination, and the use of causal inference-based approaches to study treatment for drug-resistant tuberculosis. And I will give the floor to Dr. Franke.
Thanks so much, Catherine, and thank you all for having me. As Catherine mentioned, I am EPI trained. I don't study a lot of infectious disease dynamics. I do study infectious diseases, but much more so in the context of delivery of interventions. But a lot of my career has focused on causal inference from treatment cohorts of drug-resistant tuberculosis, and that's what I'll be focusing on today. It's a little bit of a niche area, but I hope that some of the concepts that I'll be talking about, I hope you'll be able to find applicability to your own work. Okay, so just in terms of an outline, I'll talk a little bit about just my motivation for doing this work, a little bit about the background of drug-resistant TB research. I'll talk about some key problems that we see in analyses of MDR TB cohorts. And particularly, I'll be focusing on conflation between prediction and etiology studies, and then also immortal person time. And then I'll provide two practical examples of target trial emulation to try to overcome some of these limitations, and also two analyses of controlled direct effects to look at mechanisms of how comorbidities impact treatment outcomes. And I'll close with just some challenges that we've encountered in conducting this work. So really, I believe strongly that this is more than a methodological exercise, and that actually good epidemiologic methods promote equity. I'm sure we all agree that we want our treatments to be based on the best possible evidence. And I would argue that that's especially true for TB, just given the sheer numbers and the sheer number of deaths. It's the #1 infectious disease killer globally. And we also know that TB is associated with a lot of social vulnerabilities, including malnutrition, comorbidities, poverty. And so we want to do as many trials as possible to answer some of these questions, but we also want to position ourselves to generate the best possible evidence from observational studies if trial data are not available or while we're waiting for trial data. So some of you probably know this, maybe all of you know this, but so when I'm talking about MDR TB, we're talking about multi-drug resistant tuberculosis. So tuberculosis that is resistant to the two key first-line TB drugs, rifampin and isoniazid. And so historically, up until the last 5 or 10 years, treatment for drug-resistant TB was really grueling. It was long, so up to 2 years. Best case is that it was individualized based on each person's specific drug resistance pattern. That often meant 5 to 7 drugs, up to 20 pills daily, and an injectable agent, which can cause permanent hearing loss. In addition, there are other important toxicities such as nausea, skin rashes, renal failure, in some cases psychosis. And the success rate was generally not very good. So 50 to 57% globally. And if you had additional drug resistant to the key second-line drugs, it was even lower. And for many years, drug-resistant TB was largely shaped by expert opinion and observational data. The primary data source, once we started moving away from expert opinion to data, was a large individual person database that included sort of the treatment experience of thousands of patients treated globally. And in many ways, it was a tremendous resource and allowed us to sort of switch from expert opinion to data. But it did have limitations in the sense that it is not longitudinal. So in that database, there's information about things that happen during treatment, but there's no temporal ordering. So we know which drugs were received, but we don't know which drugs were received first, which were received second, why they were added. And that's in part because when you're pooling lots of different data sets, you oftentimes end up having to aggregate to the least granular data set. And so I just want to show you an example of why that matters. And it's because these longer regimens they're incredibly dynamic in the sense that drugs are constantly changing due to toxicity and, newly identified resistance or a lack of clinical improvement. So this is a graphic from a cohort of patients that received one of these longer individualized treatments. So there are 39 patients. Those are supposed to be people on the left, and you can see that those are lines going across. And the colors represent the number of drugs that were received over time. And so you can see that for any given person, that number, there are lots of starts and stops. Sometimes it's to figure out what's causing a toxicity. Sometimes it's a protocolized stop, after 8 months of receiving an injectable. But this doesn't even show you sort of drug substitutions. This just shows you changes in the number of drugs that were received. So there's a lot happening. And if you ever wanted to sort of tease out the effect of an individual drug, it's really important to understand the reasons for these starts and stops. So you can also imagine, as sort of I just mentioned, this is a cartoon illustration of what a treatment course looked like. And you can see that it's really ripe for time varying confounding and why it's critically important to understand why these changes are occurring. So a person starts treatment, will have some indication of the severity of their disease, their comorbidities. That severity of disease and their comorbidities will also likely impact their treatment outcome. They're followed over time. Oftentimes they're monitored monthly with smear and culture. Based on the evolution of that smear and culture, whether new resistance is detected, changes to their regimen might be made. And then, so drugs might be added, but then also drugs might be taken away. And that might be because they're doing better on treatment or because they had some sort of adverse event that required treatment to be changed. So the good news is that over the last 10 years, or a little over 10 years, treatment has really been revolutionized due to the introduction and approval of 2 new TB drugs, bedaquiline and delamanid. So these were the first 2 new TB drugs in more than 50 years. And they were approved on the basis of phase 2 clinical trials. And just in 2019, WHO sort of established these 2 new drugs, and particularly bedaquiline, as really sort of the anchor of an injectable-free longer regimen. So for the first time ever, patients were able to be treated without this very toxic injectable agent. And also that same year, they introduced a shortened treatment. It contained an injectable, but it was 9 to 12 months, so also offering an improvement in some way. The other really exciting thing about the introduction of these 2 new drugs is that they led to innovative trials trying to shorten treatment. So these are 3 trials that had an active comparator and tested these shortened regimens ranging from 6 to 9 months as compared to this longer standard of care. And a number of regimens were shown to be non-inferior or superior to this longer standard of care, such that just last year, there were 2 6-month regimens and 4 9 to 12-month regimens that were approved. So it seems like things are going great. We have shorter regimens, we have more trials than we ever have before. So why the hyperbolic trial about treating bias in TB studies? And the reason is that there's actually still a lot that we don't know about these regimens. And so we're inevitably going to be relying on observational data to answer these questions. And I think we're in a better position than ever before actually to be able to generate high quality data and evidence from observational studies. So just to give you some examples, one of the key questions is how do we manage adverse events? So these new regimens, one of the drugs that is a key drug is linezolid. Up to 30% of people that start this drug have to have it stopped due to severe peripheral neuropathy, but we don't know to what extent that impacts the efficacy of the regimens. We also don't know whether you can swap out a drug. So of these new approved regimens, we don't know if you can swap out a drug if one happens to be not available. And in addition, some of the trials have suggested that there are certain key populations that actually require a longer treatment. But that is not something that's been addressed in trials. Okay, so as I transition to the next section of the talk about addressing bias, I want to turn back to the individual patient database that I mentioned. And really just emphasize that historically in drug-resistant TB, in contrast to many other infectious diseases, including HIV, I think is a great example, we have not had large longitudinal data sets from which to be generating evidence. It was really this individual patient database. So I want to just point out, so this is a study from 2017. On the right, you can see a table that shows some propensity score adjusted odds ratios for a bunch of different TB drugs. You don't need to worry too much about them, but what I want to talk about right now is the interpretation of these odds ratios. So for each drug, the investigators looked in the IPD and said, did this patient receive this drug for at least a month during their 18 to 20 month regimen? What does that mean exactly? So does that mean that drug replaced a different drug? So you're holding the number of drugs constant and you replaced it? Does it mean you added that drug? So it's an additional drug that is, specific? Or more likely, is it a combination of those two things? So if we take pyrazinamide, for example, the requirement is that they only received at least a month of this drug as part of an 18 to 20 month regimen. So that odds ratio affects a very wide variation in terms of actual exposure to PZA. We also don't know why pyrazinamide was added to the regimen. We don't know if it was included from the beginning or if it was added because the patient was really not doing well. And then there are no other specifications about the background regimen. So I would argue that sort of the causal contrast here is really not well specified, and it also may not be of interest. But I think this is really a function of the lack of longitudinal data, which requires us to default to questions that are actually not really of interest and may not be able to be answered in an unbiased way. And it also means the lack of longitudinal cohorts also means that we can't avail of emerging epidemiologic methods. So this is a review from 2019 that just shows sort of the increased use of methods for addressing like time-varying mediation or time-varying confounding. That top line is observed data, and then the other lines that are a little less sort of indicate a lower frequency are simulated data and theoretical papers or reviews. But you can see that these methods have really come into the mainstream over the last 10 years. And with, certain fields like picking up these methods more so than others, I think it's probably not a surprise that some of these fields are fields that researchers here at Harvard who are working in these methods are also working. And so one of our postdocs actually replicated this review in TB in 2019 and didn't identify a single TB study that was considering time-varying confounding or mediation. She did identify a few studies, but they were all HIV-centered research studies that also focused on TB. And again, I think this may be partly due to a lack of familiarity within the TB community about these methods, but I think it more so speaks to the scarcity of longitudinal cohort data that would lend themselves to actually using these methods. Okay, so now I'm going to transition to sort of two major limitations that we see really commonly in the TB literature. So the first is conflation. So what is conflation and why do we care? So we know that predictive studies identify factors that predict an outcome, or they develop some sort of prediction model. So your goal may be to understand which particular patients might be at higher risk of a certain outcome so you can follow them closely. Your goal isn't causal. You don't need to worry about confounding, for example, because you're really just trying to predict. Etiologic studies, on the other hand, estimate a causal effect of exposure on an outcome to inform intervention. So there, your goal is causal. And it's actually quite important to distinguish between these two things because your modeling approaches are going to be different. So how you select which variables you include as covariates, how you interpret the model is different, even if certain statistical techniques like your multivariable regression model are the same. And so conflation occurs when we combine aspects of predictive and etiologic methods. So for example, we might build our model based on univariable p-values or an indicator of goodness of fit without considering causal structure or confounders. But if we then conclude our paper by proposing interventions to address those risk factors, that would be conflation because you didn't build your model to identify a causal effect, which would lend itself to an intervention. I love this paper by Miguel because it really transformed my thinking around articulating causal goals. If you haven't read it, I highly recommend it. I think what oftentimes happens is that in our effort to be conscientious and responsible researchers, we avoid articulating this goal. And I think this is particularly true in TB because we've had so many data limitations. But this paper argues exactly the opposite. And this is a quote from the paper that really specifically being explicit about the causal objective of a study reduces ambiguity in the scientific question, errors in the data analysis, and excesses in the interpretation of results. So we looked at conflation in the TB literature, and what we basically did, we were inspired by a scoping review that had been done by this investigator named Ransbeck. And what they did was they actually did a scoping review of conflation in top tier medical journals. So conflation between etiology and predictive studies. And they found that 26% of studies were conflated. So two postdocs, Matt Romo and Lucia Barcellini, replicated this, focusing on TB journals. Does anyone want to take a stab at what percent were conflated?
50.
Ooh. Yeah. 80% were conflated. And this is sort of a Venn diagram that shows like the ways in which conflation occurred. And if you look at the two big circles, the most common ways conflation occurred is that you had a causal interpretation of predictors in a study with a predictive research question or a predictive statistical approach, or that the investigators recommended proposed intervention that modified exposures in a study with a predictive research question and or statistical approach. This is, I'll sort of walk you through this in a minute, but I do want to say, lest it sound like I'm being very critical of TB researchers, I do have a paper in this. I don't know the outcome, but I suspect it is not one of the two papers that was not conflated. And so what you can see, so the columns going across, that first column is the research question. The second one is the statistical approach, results, discussion, and then overall. So what you can see is actually half of the research questions, it was unclear about whether the goal was prediction or causal. So that's a tough foot to start from. And so basically that last column, if there was conflation within a section of the paper or across sections of the paper, that paper was marked as conflated. And while 80% were conflated, among those that weren't, 5 of the 6 of the 8 were unclear. So only 2 were both clear and unconflated. Okay. So that's conflation. Then the next point that I want to talk about briefly is immortal time bias. And I know that everyone kind of roughly knows what this is in this group, but I just want to talk briefly about 2 different types of immortal time bias that we see a lot in cohort studies. The first arises when in survival analyses, when individuals are assigned to treatment strategies based on post-eligibility information, even though the treatments are not distinguishable at time zero. So what does that mean? So we see this a lot in analyses of treatment duration. And this occurs because in analyses of treatment duration, at the beginning of treatment, you don't know how long that person is going to be treated for. That is not something you can identify at time zero. And so you can only determine their treatment strategy later after you see how long they've been treated. And so this is the bias that occurs because you have to survive longer to be treated longer. The second way in which a mortal time bias can occur, and I'm just going to mention this, I won't talk too much about it, is when individuals are selected based on post-assignment eligibility criteria, but analysis starts at assignment. And so where we see this a lot is in analysis of culture conversion in TB. So culture conversion is an interim outcome that we see a lot in TB. So oftentimes individuals are culture positive at the beginning of treatment, and then in the presence of successful treatment, that will convert to negative. And so to be included in that cohort, you need to have a positive culture. But in reality, oftentimes at our time zero is the start of treatment, but we don't actually have the culture at the beginning of treatment. We might get it a week later, 2 weeks later, 3 weeks later. And we might include them anyways, just to make our sample size a bit bigger. But that comes at the potential cost of immortal time bias, because you have to have survived to get that second culture. So we actually see immortal time bias with regard to treatment duration all the time in the TB literature. This was a paper that was published in CID looking at the optimal timing of antiretroviral therapy initiation in children and adolescents with both HIV and TB. Now, the investigators that did this study, they actually did correct for immortal time in their regression analysis, but it's not corrected for here in the survival curve. And so I just want to explain why. So here you see there are 4 lines. That red line at the bottom are the group of individuals that never received ART. The green line just above that are those children that started within 2 weeks. The dark blue line is within 2 weeks to 2 months. And then the light blue line is individuals that started greater than 2 months. And so let's just talk about that last line, that sort of like sky blue line. So what's happening with that sky blue line is all of those children needed to survive to 2 months, but all of their unexposed to ART person time is being classified in that greater than 2 months group, when we actually know that it should be classified in the no ART group, which would bring these arms much closer together. So there's systematic misclassification of exposure here. And I think one of the challenging things is this is always going to favor treatment. And so you actually see this a lot, specifically in this context of HIV. And we know that ART is effective. And so, it's very easy to miss, but it will always favor treatment. Here's another study that was published in Lancet ID just at the end of last year. So in their paper, the investigators wanted to analyze time to death with bedaquiline duration included as a continuous predictor. We don't actually even need to know the results of the study to know that it's associated, just because we know that in order to get longer treatment, you had to survive to get that longer treatment, and the death rate among individuals with bedaquiline-resistant TB is high. And so we can pretty much guarantee that there's going to be immortal time at play. They did say that they would, to mitigate immortal time bias, they would do a sensitivity analysis, including only patients who survived at least 8 weeks. The problem is, this is the survival curve for that cohort, and you can see that deaths occurred well beyond 8 weeks. The rate of death was relatively high, and it was happening very consistently throughout treatment. So that's not something that would be addressed by this sensitivity analysis. So it's not surprising that they both saw an association between bedaquiline and reduced mortality, and it was a bit attenuated in the sensitivity analysis, but I think it's pretty clear that the immortal time is still present. Okay, so now I'm going to focus to some of the work that we've done to try to overcome some of these limitations. I'll talk a little bit about the two data sources. So the first is the NTB observational study, which was a cohort that was really designed to facilitate the rollout of bedaquiline and delamanid throughout the world. And it was at a time when the drugs were still relatively new. We knew that they were effective, but the goal was really to generate evidence in a bunch of different populations. So there was a prospective cohort study that was conducted alongside the rollout of these drugs. And that was from 2014 to 2019. And then in 2019, once these shorter regimens revealed themselves as quite effective, WHO actually suggested that countries could start using these shortened regimens, but suggested that they do it under operational research conditions, meaning that you're just collecting more intensive data and informed consent. And so we extended this cohort in 3 countries, Peru, Kazakhstan, and Lesotho. So at the time, this just shows that like studies related to duration were a huge priority. So, you know, questions about the treatment duration, but also even in the context of like longer regimens, you know, how long do you actually need to use linezolid? How long do you need to use bedaquiline and some of these other drugs? So one of the first questions that we looked at was related to the comparative effectiveness of different doses of bedaquiline in the context of these longer regimens. So in the original trial, bedaquiline was actually only used for 6 months, and so it was approved for use for 6 months. And a lot of clinicians felt like it was such a great drug, they wanted to include it for longer than 6 months, but that was considered off-label use. And so in thinking about studying this within the context of the NTB observational study, there were 2 key biases that Letizia was thinking about. The first was immortal time bias, and then the second was the fact that we knew that bedaquiline was more likely to be extended in the sickest individuals. So these were the 3 treatment strategies that she looked at, and she used a target trial approach, which I know folks are familiar with, but just broadly speaking, the idea is that you articulate that sort of the ideal trial for testing your question and then emulate it based on your data. And so she was interested in comparing bedaquiline for 6 months to 7 to 11 months to greater than 12 months. And I'm just going to show you some of the details of her target trial, because I think the target trial specification is really interesting because the devil is in those details. So for example, her trial was really focused on bedaquiline duration. So the content and the duration of the background regimen, so other drugs included, were totally up to the discretion of the clinician. Patients were allowed to deviate from their assigned treatment arm, so their assigned bedaquiline duration, for less than 2 weeks for any reason. So that was just to account for short stockouts, short interruptions, etc. Treatment individuals could deviate from their regimen due to an adverse event for any reason. And that's really just practical, because if a clinician feels like they need to stop a medication, you're not going to tell them not to stop that medication. And so if you were to censor people when they deviated, that would be sort of creating a world in which adverse events don't occur. And so that doesn't make sense. And then finally, bedaquiline can be reinitiated after stopping if clinically indicated. That occurred very rarely in this cohort, but it did happen. And so one of the things that I just think is fantastic about target trial emulation is it's so explicit. You are really kind of putting your assumptions out here, and you can say, I don't agree with that. That doesn't make sense to me. But at least it's out there for people to discuss and ponder. And so in order to, I've talked a lot about immortal person time bias, and I'm sure some of you have probably heard about sort of the cloning and censoring and weighting approach. that you can use to adjust for immortal time bias. And that's what Letizia used. And I just want to sort of give a brief demo of what that looks like in practice. It will be short if the idea of understanding what's under this hood is not appealing to you. But okay, so these are 6 individuals. And at baseline, so the first step is to identify all of the treatment strategies that are compatible with each individual at baseline. So you can see of these 6 individuals, I've indicated with the circles the 2 individuals that had stopped bedaquiline at 6 months. And so their regimens were compatible with regimen 1, with treatment strategy 1. The other 4 with the arrow were still on bedaquiline at time 0. And so you could argue, and fairly, that their treatment strategy at time 0 is consistent with both receiving bedaquiline for 7 to 11 months or more than 12 months. So we assign DNF to treatment strategy 1, and we make a copy of people in A, B, C, and E, and we assign them to both treatment strategies 2 and 3. And then the next step, which I won't talk too much about here, would be to censor them. So for example, the person that is assigned to treatment strategy 2, bedaquiline for 7 to 11 months, if they don't stop bedaquiline by 11 months, you'd censor them and calculate some inverse probability weights. And likewise for patient A, patient A clone who's assigned to treatment strategy 3, bedaquiline for 12 months, if they stop bedaquiline before that time, you would censor them at that point and use inverse probability weights to account for that. So just to show you the results of Letizia's analysis. So she first conducted sort of the naive analysis in which she, calculated effect estimates based on the observed duration and found that actually a longer duration of bedaquiline was positively associated with treatment success. The success ratio was 1.09 with a confidence ranging from 1.05 to 1.14. But when she did this cloning, censoring, and weighting approach with inverse probability weighting, that bedaquiline for greater than 12 months was no longer associated with treatment success. And I think, all of the evidence that has come out since this paper also supports that, just by the fact that we now have 6 months bedaquiline-based regimens. This was conducted in a longer cohort, but I think even though there hasn't been a trial, I think the vast majority of evidence supports now that 6 months of bedaquiline isn't enough, or is enough. Okay, I'll now just move on to a second target trial example. So another key question is, the fluoroquinolone is a cornerstone drug for multi-drug resistant tuberculosis. And so what happens when a person has fluoroquinolone resistance and can't take that? So this was a question that Cheng Bo-Zen asked, was how do we reinforce regimens for patients with fluoroquinolone resistance?
Well, you just ask both for the other paper and for this one. The starting context is there's a full understanding of what the isolates are and what they're resistant to, and the regimens are designed based on that, or are these empirical regimens, and are they all on the same regimen?
So they're not all on the same regimen. So if you think back to these are the patients who were receiving longer individualized regimens. So if you think back to that heat map that I showed at the beginning,
yeah,
they're receiving probably there's hundreds of different combinations that the individuals are receiving. So, I think a fair criticism of the last paper, for example, would be, we compared different bedaquiline durations and we adjusted for some regimen characteristics, but then there's sort of an outstanding question of, have you accounted for all of the different
variations?
Yeah, exactly. Yeah, and I think, for the most part, there is some variability in the extent of everyone had documented MDR TB. Most people, not everyone, had fluoroquinolone testing. Some people had even more expanded testing, but we also know that some of those are not fully reliable. And so there are, certainly, and this will come up here, patients were probably also receiving drugs to which they weren't susceptible as well. And I will talk about that in a minute. But does that sort of answer your question? Any other questions before I move on? Okay. And so the idea behind this analysis was to take a base regimen of bedaquiline for 5 to 8 months, plus linezolid and clofazimine, and say, look at a few different strategies for reinforcing that regimen. So this was just the criteria for the target trial. Really just what I want to call your attention here is the, because everyone in this trial was going to receive bedaquiline, linezolid, and clofazimine, we wanted to ensure that everyone had likely effectiveness to these 3 drugs. So that either means that they had a DST demonstrating susceptibility, or they at least had not been treated for a month or more in the past. And so these are the different treatment strategies that Changbo looked at. So the sort of the baseline regimen, I already told you this. So the second strategy, prolonged bedaquiline. The third added delaminid. The fourth added imipenem. The fifth added a second-line injectable. And the sixth arm included delaminid and imipenem. So just to talk a little bit about some of the other aspects of the target trial. So clinicians were allowed to determine the total duration of treatment for each drug, except bedaquiline, which was protocolized into one of 3 durations. So either at least 5 months, 5 to 8 months, and greater than 9 months. So if you're like really dialed in here, you might notice that that's the greater than or equal to 5 months is a little odd and a little broad. And that was in part because there was just like among the people that had received these certain combinations of drugs. So for example, among those that had received imipenem, there was such a wide variation in terms of who had received, in terms of the duration of bedaquiline received, that we just that was the strategy that we were able to examine given this data set. So you can argue at that point, but I think at least it's specified there very clearly. Then some of these are the same, so I won't too much. Oh, this is another strange one, but again, something I'm glad that is articulated here. So drugs other than those assigned to the regimen can only be included if they're unlikely to be effective. So that is kind of a weird thing to say, in a trial, because a clinician would never presumably likely add some drugs that they didn't think were going to be effective. But in practice, we had to add that because in practice, in our data set, patients were receiving drugs to which they were unlikely to be effective. And that may be because either resistance hadn't been identified yet, or maybe the DST wasn't super reliable. And so the clinician thought, well, I'm going to add it just in case. But again, I think there's something to be said. It is a little weird, but at least we're being very transparent with the protocol that we are testing. The other thing that is interesting about this target trial is that you can imagine that if you were actually doing this trial, we only required susceptibility to the 3 first-line drugs, or the 3 bedaquiline, linezolid, and clofazimine. But you can imagine if you were doing the trial, you wouldn't want to randomize someone to a drug to which they weren't susceptible. So you'd probably do a stratified randomized trial, like something like this, right? So, the people that didn't have susceptibility to any of the other drugs that you were using for reinforcement could actually only be randomized to a longer duration of bedaquiline. Whereas if people additionally had susceptibility to delaminid, then they could be randomized to 3 arms. If they had susceptibility to all of the drugs, they would be in a strata in which they were eligible to be randomized to any of those. And then when you were analyzing your data, you would analyze them within strata. And so that was part of our emulated trial. But of course, in an observational setting, we wanted to be able to take advantage of all of the people that received each of these regimens. And so if you can make an assumption that the baseline risk is comparable across these data, then you can aggregate across them. And that's something you can test in your data. And we did. So these are the results from this target trial analysis. I mean, ultimately, out of a cohort of 2,700 people, I think there were about 450 that were included in this analysis. And so I think it's a little bit hard to know how to interpret the results. I think there's maybe a little bit of a sign that reinforcement with a second line injectable or delaminated imipenem, maybe offer some protection, but the confidence intervals are obviously very wide here. And I think this really sort of speaks to kind of where we are with the data generally, which is that we, like practically speaking, still don't have large enough data sets to really be able to answer definitively a lot of the questions that are of interest. So I'm going to transition away from target trial and just show a couple other examples of sort of work in the causal space that we've done, but I'm happy to take any questions about this before I transition. Okay. Yeah.
So trying to put this into context where I know bedaquiline resistance has become a bigger and bigger issue. The data for these, how do these intersect with the timelines for the increased prevalence of bedaquiline resistance?
I would say proceed, yeah. So towards the end of this study, there was quite a bit of testing for bedaquiline resistance, but this was really still part of this. The data for this were collected from 2014 to 19, very much during the rollout. So bedaquiline resistance was quite rare during that time.
I was wondering if you could say more about who were the 450 people who were included, and at which step of the target triangulation you lost more people, and how different they were from the people who were not included and stuff like that.
Yeah, that's a great question. Really, so as I mentioned before, because these were longer individualized regimens, the number of different combinations of treatments were in the hundreds. And so what we did was we looked at what are the most common regimens that people received. In this core of bedaquiline and linezolid, which are the two priority drugs, and then clofazimine, which is sort of a second tier drug, was used very commonly with usually another agent. And so that allowed us to know that we could probably, it was one of the more common formulations. And so that most of the dropout was just due to patients who received a regimen that was not of interest. It's a great question. Okay, I'm now going to switch gears a little bit to talk about some work that we've been doing with regard to comorbidities. So probably many of you know that comorbidities are very common in TB. So HIV, diabetes, cardiovascular disease. And we know that because there are a lot of sort of what I would call risk factor studies. I've done them myself. So it's no knock on a risk factor study, but I think those are sort of the ambiguous studies where you're not sure, you're looking at predictors, but maybe you're adjusting for confounders. So like kind of what's the goal? And sort of when we looked through the literature, we realized that there are a lot of comorbidity studies that are not super intentional in thinking about causal structure and what variables you're adjusting for, because some comorbidities themselves impact TB presentation. So you can imagine that we know people with HIV present differently than people without HIV. We know that smokers may be more likely to present with indicators of severe disease. And so whether you choose to adjust for those variables or not depends on whether they are a confounder or they're actually on a causal pathway. And sometimes we actually just don't know. And so the goal of the work that I'm going to show next was really to estimate the the overall effect of specific comorbidities on treatment outcome, and then also try to understand a bit more the mechanisms through which these comorbidities might be resulting in different treatment outcomes. And we did that by conducting controlled direct effect analyses in which we simulate an intervention that holds a mediator constant. So the first question that we looked at was focusing on HCV. And you can imagine that there are a few different ways that hepatitis C might be associated with treatment outcomes. So the first is simply confounding. There may be important differences with regard to how people with HCV and without HIV, there may be different confounders there. It may also be due to differential adherence on treatment. It might be associated with different rates of medication-associated toxicity. So folks with HCV might be more likely to have hepatotoxicity. And it also might be due to different prescribing practices. So maybe clinicians are, more likely to prescribe fewer drugs to folks with HCV, hoping to protect the liver a bit. So sort of these were our hypothesized mechanisms. And the study that Ali Lahoud did specifically was honing in on these two, sort of the differential adherence and the differential prescribing practices as potential mechanisms. And so this shows the risk difference, so for an unfavorable outcome. So in the unadjusted analysis, you can see that HCV was associated with a higher rate of unfavorable outcome. When you adjusted for baseline confounding, that was attenuated a little bit, suggesting that was probably part of the story. And then when she intervened, she simulated an intervention of what you might expect if everyone was retained in treatment and had at least 80% adherence. You can see that the effect estimate drops even further, but that there's no additional drop when you intervene on a strong regimen. So what this suggests to me is that, it seems like differential adherence may be part of the story. It doesn't seem like after accounting for differential adherence, sort of this differences in prescribing practices is really too much of the story. But that certainly, there may be more to it. So there may be, we weren't able to actually test the hepatotoxicity mechanism in this study. And you can still see, while the confidence intervals are pretty wide towards the end here, it does look like there's still an elevated risk. So I think of these studies really as kind of hypothesis generating. And I think up until now, there's been a large assumption or an important assumption that a lot of the time when we see an association between a comorbidity and an unfavorable outcome, that it's biological, that it's something, and it doesn't necessarily account for sort of the social aspects that go along with comorbidities. And so then we conducted a similar analysis for smoking. And the focus here again was on differential adherence and how that might be impacting or how that might explain any association that we see between smoking and unfavorable treatment outcome. And this was work that was led by Matt Romo. Sort of confusingly, this graph actually shows treatment success as opposed to a risk it's a success difference instead of a risk difference, so going the opposite way. So here, smoking, we still see a harmful effect of smoking in the unadjusted analysis. It's attenuated a bit in the baseline adjusted analysis, and it's attenuated almost to zero after you simulate an intervention in which everyone is attained to treatment. And so to me, again, it just sort of suggests that there may be an important social side to the story, and that actually part of, not to say that there's not a biological effect, but that actually part of the disparity in unfavorable outcomes that we see among smoking, it seems to be partially driven by higher rates of loss to follow-up among smokers. So in case after this talk, folks are interested in causal methods in the TB space, there is a ton of ongoing work in this area. So I mentioned these sort of innovative cutting edge trials. Ali LaHood is currently working on a project that combines the trial data because we don't have direct head-to-head comparisons of the approved regimens. And of course, we would love that. There's work being done to look at the transportability of trial results beyond sort of the target population of the trial. There's target trial work to really understand strategies for managing adverse events, analyses that are looking at sort of subgroup analyses of trial data, and then also kind of re-examining the estimands that are used currently in WHO analyses to sort of identify how you might, which ones are relevant, and for those that are relevant, how can we estimate them in the least biased way possible. My last slide, I do just want to highlight some ongoing challenges in this work. The first is that even though, we now have a cohort of around 3,000 people, and it is probably one of the largest cohorts of its kind, it's still a really small sample, and we are having to make concessions on research questions, and our confidence intervals are still wide, which make of course, it hard to draw conclusions with any certainty. I think changing practice in this space is really slow, in part because there are so few methods folks working in this space. We found it very hard to find peer reviewers. In fact, Ali's paper that was published in AJE, the editor let us know that they had to invite an unprecedented number of reviewers because people felt comfortable in the TB space and the method space, but not the TB method space. And then I think a final point is that I think it's really unclear how WHO will consider observational studies with regard to treatment guidelines in the future. I think, it's exciting that we now have a lot of trials, but I think, the last guideline review suggests that kind of observational studies are still in the space where they're all sort of viewed as suboptimal rather than on a spectrum of, mediocre to good. And I do firmly believe that there is a role for observational studies in guiding TB policy in the future. I will always be an advocate for more trials, but I do think we need to equip ourselves to be able to generate good evidence from observational studies. So I will end there. And I think we have a few minutes left for questions.
Yeah, maybe one or two questions, and then we're very fortunate that Professor Franke is here, so can also follow up after. But does anybody have a question?
Yeah, so firstly, fantastic. These methods are, I think, inherently complicated, and that was a very clear description. I've got a question about the risk factor side of things. And so, as you all know, there's a lot of interest in nutrition. With the rations trial, it motivated a lot of people. I think of nutrition as being one of the thorniest problems about sort of understanding the role of nutrition and nutritional supplementation during treatment. Is that something that these methods could be applied to? I say that just because the rations trial is a very special population. Like, they were really malnourished. And so, can these methods be used to sort of broaden the evidence base?
Yeah, I mean, I guess I need to know a little bit more about kind of how you're thinking about that. Like what would be the thing that you would, like, what would be the question that you would want additional information for?
Nutritional supplementation during treatment for people who aren't seriously malnourished or like at higher levels of.
And does that improve your treatment outcome?
Yeah.
So the way that I could imagine that working is that if in like a given place, there were people that sort of like in you're referring to kind of an observational context. Yeah, I mean, I think if there are kind of natural experiments in the sense that like you have data from a world where, maybe there was like a World Food Program donation during one year, but not the next year. And you had good data on you know, differences between those two populations, that's where I think kind of like the causal framework can be helpful. But I think trying to figure out a population, like kind of thinking about, you know, those natural experiments are pretty rare, but they do happen. So I think it's just a matter of kind of like figuring out whether that exists.
So you're heading towards something quasi-experimental rather than trying to use some time varying compounder approach to.
Well,
Purely observation.
I guess, so I think it all comes down to articulating your target trial, but if you're talking about like a scenario where people are receiving, I think you can use these methods if, for example, you know, you were interested in food supplementation for the entire duration of treatment, and you're working in a population where, you know, sometimes based on the discretion of a doctor, sometimes they receive it for 3 months, sometimes they receive it for all of treatment, sometimes they don't receive it, but you think there's enough variability. I do think these methods can be very useful. Yeah.
Juan?
I have a question. I've been working on antibiotics in patients, and one big problem that I have is the confounded by indication, and even having a lot of variables from the clinical records, it's difficult to like make it go away. I was wondering if you found the same problem.
Yes, I do think, I mean, I think one of the benefits of working like across countries is that they're like sometimes countries just use different drugs. And so there was natural heterogeneity in that sense. I think that also comes with its own set of challenges because then you need to worry about like kind of site specific factors that are confounding that. But I do think, you know, I think it's always a problem to a certain degree in our work, but usually like we have pretty good ways of measuring TB severity at baseline. So that if it's not perfect confounding by indication, which I think in this setting it rarely is, you can typically make the appropriate adjustments. So I wouldn't say it's like the most important source of bias, at least for these analyses.